I enjoy being here with you virtually anyway today. I wish I could enjoy your meeting in person, and look forward to meeting all of you some other day. I was asked to talk about orbital procedures for the endoscopic surgeon. I'm Rakesh Chandra. I go by Rick. I'm a professor of otolaryngology and chief of rhinology at the Vanderbilt University Medical Center. And there you see my contact information if you ever wish to get in touch with me directly. So first, some orbital anatomy. This is a schematic view of the right side. That most of these, there's 7 bones that make up the orbit. The infraorbital fissure and the superior orbital fissure and the optic canal are best remembered by me with regard to their relationship to the greater wing of the sphenoid, with the inferior orbital fissure being between that and the maxillary bone, while the superior orbital fissure is between the greater and lesser wings, and the optic canal occupying the lesser wing. So many times we think in an axial plane of the orbits as being 2 parallel V-shaped areas. The orbital cone, as it's often called. This is really a misnomer, because the orbits are really conformed like this, where the medial orbital wall is more in a sagittal plane parallel to the nasal septum. So the orbital cone isn't really a V-shaped cone the way sometimes it's conceptualized. And that's important understanding when doing orbital decompressions and dacrocystorhinostomies and some of the procedures that I'm going to illustrate for you today. So this is what that looks like. There's also some globe, obviously, and then the optic nerve. There is some physiologic tortuosity to the optic nerve itself, and in the posterior aspect of the medial orbital wall, it's where it transitions to the optic canal, that this bone here is often part of a dissection when needed to do optic nerve decompression. So I'm going to start talking about the lacrimal system and dacrocystorhinostomy, and then we'll move through some of the other procedures, including the various forms of decompression. So the ophthalmologists or the oculoplastic surgeons use this rule of tens, where the lacrimal canaliculus has a 10 millimeter length, where the first 2 of it is vertical and the other 8 is horizontal, and then you have this common canaliculus, and then from the common canaliculus, the sac is about 10 millimeters as well. And then there's the fundus of the sac, which is a smaller amount above it. So the canaliculus is important to remember that a lot of times if you're working with an ophthalmologist, they're going to be the ones that probe it from this direction. But if you ever need to probe it, it's important to remember that you have to pull the eyelid laterally so that it stretches out this vertical part and puts it in profile with that horizontal part there. Mostly as otolaryngologists, when we're doing endoscopic sinus surgery, we're concerning ourselves with this intraosseous part of the nasolacrimal duct, because that's the part that we don't want to injure when we're doing maxillary antrostomy. But when we're doing dacrocystorhinostomy, we're interested in that part up here. So this is what that anatomy looks like, the schematic looking at the middle turbinate, the uncinate process. Now, the anterior attachment of the uncinate process into the lateral nasal wall is called the maxillary line, and it just so happens that the maxillary line correlates with the maxillolacrimal suture line in the orbit. So perhaps if we go back a few slides, that maxillolacrimal suture line is very important, because the lacrimal gland sits in this fossa here. The anterior lacrimal crest is formed by the maxillary bone. The posterior lacrimal crest is part of the lacrimal bone. You see it better in this diagram. So this is the posterior lacrimal crest. This is the anterior lacrimal crest. This is the lacrimal fossa. The lacrimal fossa is bisected by that maxillolacrimal suture line. And that's the suture line. That suture line correlates with the maxillary line in the nose. And so when we are, I guess I showed you that here. So we're going to use that maxillary line as our primary landmark. So the indications for endoscopic dacrocystorhinostomy are post-saccular obstruction. This can be primary it can be secondary. We see this a lot in the setting of previous radioactive iodine for thyroid disease. We see it in the setting of radiation therapy for malignancies as a delayed effect. Sometimes also patients have had resection of the lacrimal duct during tumor surgery, even inverting papilloma. And then we can also do this endoscopically. It's important to note not just for primary cases, but also for failed previous cases, including previous ones that were done externally. So procedure begins with this incision here along the maxillary line, also creating a flap here over where the sac sits. Then this mucosa there's no reason to preserve that island there. It can be sacrificed. And then using curettes or a Kerrison Roger, I find as an effective tool. Sometimes you do need to use a drill to remove that bone there. And then we're exposing the soft tissue of essentially the medial hemisphere, as well as some of the anterior face of the lacrimal sac. And then taking a patch of tissue out there. It's important, especially in cases where the lacrimal duct obstruction is idiopathic, to sample this tissue. Occasionally we find things like sarcoidosis or Wegener's granulomatosis in that tissue. So that tissue is removed for histopathology. Then these stents are passed through the upper and lower canaliculus and retrieved in the nose, and then secured to one another. These stents stay in there for 3 months. The process of cannulating that duct is done by the oculoplastic surgeon, and one useful adjunct that they sometimes use is this light pipe, which is a transillumination method for us to see where that lacrimal sac sits on the side wall of the nose. So in this case, I'll have a little video to show you. We're just starting off by injecting the area there with some 1% lidocaine, 100,000 epinephrine. This is the maxillary line. There we've made an incision, and we're going to extend that incision a little bit just above the axilla of the middle turbinate, and we're going to bring the mucosa down. This mucoperiosteum usually elevates fairly easily with a caudal elevator or so forth. We'll speed this up a little bit. So now we see the bone a little bit better here. So in this case, I'm going to use a diamond drill, but before going to that, you see that light pipe where it's transilluminating the undersurface there, and it's just a nice confirm. The ophthalmologist or the oculoplastic surgeon is just tapping that probe through there, tapping that probe in the sac underneath the bone there, and now we're using a drill to take that bone down. It's important not to let the medial side of the drill abrade the septum in that area. Now that after removing the bone, the light pipe comes through at this point. When using the light pipe, it's also important to know that you sometimes need to turn the light on your endoscope down, or else it will eclipse the light of the transillumination. Now we're passing these stents through on each side, one through the upper and lower canaliculus, and they'll be secured to themselves in the nose. So now I'm going to move on to orbital decompression. Indications for that include hematoma, as well as abscess and cellulitis, orbital mass. Sometimes we need to take a route through the medial orbital wall to resect that, and it's effectively the same procedures in orbital decompression. And then also for Graves' ophthalmopathy. So orbital hematoma, the etiologies of this can be, there's essentially two of them that happen. One is when a simple orbitotomy with fat exposure is unrecognized, and there's capillary bleeding into the orbit. That's usually a much slower, gradual process. The other, which is much more acute, is when the anterior ethmoid artery is transected and retracts into the orbit, and that's much more of a rapid expanding compartment syndrome. The expanding intracoronal pressure increases the intraocular pressure. That intraocular pressure causes optic nerve ischemia, but it also is self-propagating because the increased pressure in the closed intraconal space also inhibits venous outflow, and that further exacerbates the situation. It's thought that about 2 hours of acute optic nerve ischemia can cause permanent blindness, so this really is an emergency. This is what a patient with that looks like. You see the patient, this would be a complication of endoscopic sinus surgery. The patient has pain and proptosis and chemosis and lid ecchymosis. The chemosis is from the venous outflow obstruction. These patients will have vision loss, ophthalmoplegia, and the afferent pupillary defect. You can see the ophthalmoplegia compared to the other eye. The first step in this situation is remove the packing and massage the eye. But this patient will need an orbital decompression. If the onset's gradual, again, it most likely reflects an unrecognized fat exposure, but if it's sudden and explosive, then it's usually a transected anterior ethmoid artery. There are a lot of medical methods that are in the literature for this, but this is a surgical emergency for decompression. Another teaching point with this for registrars and so forth is that although you can consult ophthalmology in this situation, you cannot wait for them before performing decompression. Now, the first step in decompression, the most acute thing you actually can do is a canthotomy and tendinolysis, and that's where this looks at the left eye. Here is the lateral canthus. You can either crush that tissue with a hemostat or inject it with lidocaine and epinephrine, and then incise laterally to the orbital rim. This will decrease intraocular pressure by about 15 millimeters of mercury. But the other important step is to then turn the scissors inferiorly and transect or disinsert the inferior crus of the lateral canthal tendon. And this causes about another 15 millimeters of mercury reduction in intraocular pressure for a total of about 30. So this is what temporizes the situation and buys you time and causes the most rapid way to reduce intraocular pressure in these situations. The next step would be, though, is to take that patient to the operating room and decompress the medial orbital wall. I'm going to illustrate that to you in the context of some other cases. So now I'm going to switch to a different case where this patient has orbital abscess and cellulitis. Interesting. This MRI demonstrates very nicely how if you look at the normal eye, there is that physiologic tortuosity of the optic nerve, but when the pressure in the orbital compartment is elevated, in this case from inflammatory disease, that the proptosis puts that optic nerve on stretch, and that further increases the ischemia of the optic nerve by pulling the vessels in the optic nerve sheath taut with it. And so this is another indication for orbital decompression. And in a case like this, one could temporize the situation also by doing a canthotomy and tendinolysis, as I showed you for the hematoma. Another indication for an orbital decompression is a mass in the orbit right there. You see also in this other view. So I'm going to illustrate now. We talked about three indications: one, the hematoma; one, the inflammatory disease; and the other, a mass, where we would take this approach. In an acute setting, if the patient's losing vision, you can do the canthotomy and tendinolysis, but the more definitive procedure for this is a medial orbital wall decompression. This starts a lot like endoscopic sinus surgery, where the maxillary line is incised and the Untitled process is removed, expose the ethmoid bulla, just like conventional endoscopic sinus surgery. We have completed the ethmoidectomy back to the sphenoethmoid angle. There's the sphenoidotomy. And then we start chipping away bone of the medial orbital wall. And just to do this in a controlled manner, it's nice to do this so that you're keeping, for the time being, the periorbita intact there. This is a lot like unshelling a hard-boiled egg, taking that out. It's a maneuver that I didn't illustrate here, but that once you've made that window through the lamina papricia, it's nice to take a thin, freer elevator and put it in the pocket between the lateral surface of the laminar bone and the orbital periosteum itself. And then you can fracture bits of the lamina by pushing the freer from lateral to medial. So once we've done that, we see the periorbita with the fat behind it. This strut here at the upper aspect of the maxillary roof medially, oftentimes we seek, well, most of the time we seek to preserve that so that the patient doesn't get post-op diplopia or hypoglobus. Then using, I like to use an arachnoid knife for this, that we make incisions in the periorbita. Sometimes, just depending on the patient's anatomy and where the septum and middle turbinate might be, it's more convenient to make these incisions vertically. Sometimes making them horizontally this way is better. Realistically, despite what's shown in this diagram, I like to make them horizontally if possible, because that way I'm making them parallel to the medial rectus muscle, which is usually deep to the fat layer by a fair amount, but sometimes it can be a little more superficial, and you don't want to injure that by cutting perpendicular to it. So usually, unlike this diagram, I'll make the incisions and parallel horizontal. Then with gentle globe massage, the fat herniates into the field. And when this procedure is done for Gray's ophthalmopathy, which is the other indication for this procedure, that the fat herniates into the field quite spontaneously, and it's a lot of times, even just when you're making those periorbital incisions, the fat starts plumping into view, and for that reason, those periorbital incisions are usually made from posterior to anterior, because if you start the incisions anteriorly, then the fat starts prolapsing in the anterior aspect of the cavity, and it eclipses your view of the more posterior areas. In this kind of a case, I'm showing you in a real patient what some of those steps look like. That here we've done, this is on the left side, we've done the ethmoidectomy, the maxillary ostium is open there. The mucosa, in this case, I elevated the mucosa and also incised the lamina in one step, and we put that Freer elevator in the space between the lamina where we're going to fracture it and the periorbita, and we're dissecting then so that the periorbita is here, the lamina with some overlying mucosa is there, and we're essentially moving the lamina from lateral to medial away, and our trajectory of force is away from the orbital soft tissues and into the ethmoid cavity where we created this nice space. Now we've taken that all the way back to the sphenoethmoid angle here. We were successful at preserving the periorbita for the time being in this case. This bone back here, just in front of the sphenoid, starts to get thicker, and this does not need a drill, but usually when I'm doing a simple medial orbital wall decompression without optic nerve decompression, encountering this hard bone is my posterior limit, and I might nibble a little bit of this out with a through cut punch or with a Blakesley forceps to fracture it in a controlled manner, but that's the posterior limit. It's important to remember where the anterior ethmoid artery is in these cases, because when we're removing the upper aspect of the medial orbital wall in the suprabular recess area, we don't want to transect it. So this is an example of where that anterior ethmoid canal would be. If you were in the frontal lecture, you would remember that when this is the suprabular recess here in the coronal view, and when there is pneumatization of the suprabular recess into the orbital process of the frontal bone, as is seen there, and the anterior ethmoid artery it runs in a canal rather than being embedded in the skull base. So in this case, it's running in a canal. The horizontal crosshair is going through it, and you see it in the endoscopic view there. And you want to be sure that when you are removing the upper aspect of the medial orbital wall, that you not traumatize the arterial canal. There's another example of it in a life where it's traversing the roof of the cavity. In this case, we've done the medial orbital wall decompression by removing the lamina. We're still going to need to make incisions in the periorbita, but it's important to notice this, because either when you're removing the medial orbital wall bone or making those incisions, you don't want to avulse or incise the artery up there. So this is another example. It's nice to look at these cases diagrammatically and then later see what they look like in a real surgical case. So we have a nice wide maxillary antrostomy. We have that strut. These are those parallel incisions I was talking about, working from posterior to anterior. that as you make these incisions with the arachnoid knife, and you'll make another one here and perhaps another one up there, avoiding the artery, as we said, and then you'll massage the globe, and the fat will herniate out through those areas. And as I stated before, in some of these severe Graves patients, or even in some of these patients with severe orbital cellulitis, the fat is under so much pressure that it just starts coming out even through the smallest part of the first incision. This is another orbital tumor case where we have essentially done the same thing, where we have taken off the medial orbital wall, we've incised the periorbita, we've a little fat there, but with the aid of stereotactic navigation, we're able to get to that tumor quite easily and directly. And this is the most direct approach, with other options being transcaruncular or lots of other external methods that an oculoplastic surgeon would employ. Graves' disease, very robust expression of fat. So some of the results with Graves' disease, this is old studies from Kennedy, that these patients had about a 5 millimeter degree of recession of the proptosis, and it was almost 6 millimeters when you combined it with the lateral wall decompression. Medicine published a little bit later showing similar numbers, a little less decompression of almost 4 millimeters with just a medial wall, and when combined with the lateral wall, again, it was 5, almost 6 millimeters of recession of the proptosis. So general rule of thumb is that you get about 4 millimeters of decompression by removing the medial orbital wall, and an additional 2 millimeters with also removal of the lateral wall, so-called balanced decompression. These transantral decompressions to remove the roof of the maxillary sinus for decompression, those are being done less and less because that probably increases the risk of diplopia, although there are some patients with severe Graves where we also need to employ that adjunctive maneuver. So usually we're either doing a medial or a combined medial and lateral decompression. Postoperatively, these patients are put on nasal saline irrigations and antibiotics, and they're essentially managed like a fess cavity when we debride them very gently at 5 to 7 days postoperatively, trying not to disturb the fat. That fat, interestingly, by almost a week postoperatively, the herniated fat has nearly completely atrophied, but we still try to avoid traumatizing it with a medial rectus and so forth. It's going to be embedded in there. And later on, by about a month, that area mucosalizes and it looks like an ethmoid cavity. So complications from decompression, diplopia is the main one. Hypothetically, some of these patients can get obstructions of adjacent sinuses and sinusitis, although we don't see that very often, especially because the fat atrophies. And in most cases, although I didn't illustrate that, we also remove the body of the middle turbinate so that herniated fat or the decompressed fat has a space to decompress into. So optic nerve decompression indications for that are acute trauma, which also can include inflammatory causes. Also can be chronic reasons why we need to chronic pathologies why we need to decompress the optic nerve, including tumors and an occasional case of Graves. The timing of the surgery for an optic decompression really depends on the progression of the disease, and that's also true for orbital wall decompression. And also the other factor is patients' comorbidities. For example, some patients after trauma might have more pressing neurocranial issues. This is an example here where the optic, I mentioned this before when we were talking about medial orbital wall decompression, but when patients have a lot of proptosis and that optic nerve is on stretch, it almost like that Chinese finger trap that as you pull on it, the caliber of it gets more and more narrow and tight and restrictive, and that further exacerbates ischemia in the nerve. The first sign of optic neuropathy oftentimes is loss of color vision, but also loss of acuity in the Marcus gun pupil, and the ophthalmologist will see papilledema early on and pallor of the optic disc later. You have a small time window because the optic nerve does not like being put on stretch like that. So the optic nerve, where it sits, variable from patient to patient. We're maybe used to thinking of it from endoscopic sinus surgery, where it sits in the sphenoid cavity. In this case, where the anterior clinoid process is pneumatized, it'll look like it's sitting out in space like that. Here you see a nice example of the optic nerve with the optico-carotid recess and the carotid canal. In other cases, that optic nerve is seen in a much more classic way, embedded in bone in the sphenoid roof. Other times, the anatomy can be variable from side to side, as you see here. So another anatomic variant is the so-called anode cell or the sphenoethmoid cell. In this case, is when an ethmoid cell pneumatizes superiorly and laterally to the sphenoid cavity proper. So this would be the right sphenoid. The left sphenoid is over here, and that's that so-called anode cell. It's seen on axial and sagittal CTs, actually. So in this case, the crosshairs is in the right sphenoid sinus. Here is the left sphenoid sinus. This is the anode cell, which is sitting superiorly and somewhat laterally. The significance of that is that the optic nerve, when this anode cell is present, is frequently dehiscent in that cell, and that's what you see here. Sphenoid sinus, anode cell. This would be the ethmoid skull base there. Here is the optic nerve. So where that optic nerve is back there depends on that posterior ethmoid and sphenoid anatomy that we pay attention to for even our routine endoscopic sinus surgeries. This is really an extension of the medial orbital wall decompression, where we would have taken all of this out already, and then we use a diamond drill as well as small curettes and carousels to unsheath this bone. The controversial maneuver is whether to incise this optic nerve sheath, because there's some concern that the optic nerve sheath might be very restrictive of the nerve in that area, but there's also the thought that by incising it, even though you may relieve this restriction, that you could cause a injury to the fascicles or to the vasculature that may undo the value you might have otherwise created by the decompression. This is what that looks like in diagrammatic form. We've done a medial orbital wall decompression as we would have before, but we've just extended the dissection along the course of the optic nerve as we've identified it radiologically and endoscopically. So this is what some typical anatomy of what that looks like on the right side. Our elevator, the shaft of it is moving the contents laterally so that we can visualize and work in the area. It's important to note that before incising the periorbita, we need to address the part more posteriorly. We're always doing these dissections from posterior to anterior, because if we started incising the periorbita before working on the more posterior areas, the fat will herniate into the field and obstruct our view of these more posterior parts of the field. In this case here, we're using a diamond drill to come back there, and then almost like I showed you with the medial orbital wall removal, that we're chipping the bits of bone from lateral to medial into the post-dissection cavity here, so that our trajectory of force is away from the orbital soft tissue structures, and then gently removing those fragments and defining the course of the optic nerve posteriorly. Some new trends include use of this ultrasonic bone aspirator, which ablates bone with low temperature and preserves the underlying soft tissue. So the other discussion about this is incising that optic nerve sheath, as well as the annulus of Zinn, which is a common tendon which encircles is the origin point for the extraocular muscles. That annulus of Zinn, it's whether to incise it or not is variable and controversial for the same reasons. It's controversial to incise the optic nerve sheath in general, which that you can cause vascular injury, and also CSF leak. That annulus of Zinn encircles all of these structures you see here. This is a schematic on the right side where the nerve and its optic nerve and its the ophthalmic artery that courses with it, which fortunately usually is not situated medial, but either inferior or lateral. But typically, once we encounter the soft tissues underneath the optic canal bone, we we stop at that point unless there's already full-on blindness. One of the sort of exam questions for students here is what's included within the annulus of Zinn, and I remember the mnemonic are not outside. These structures are not outside the abducent nerve, the nasociliary nerve, as well as the optic and oculomotor nerves. Traumatic optic neuropathy, this is a study from 2008 in 46 patients that these patients were decompressed when the acuity didn't improve after 6 days of steroids. About 2/3 of those patients got better, and amongst the ones that were effectively blind with no light perception, they got light perception in about 17, hand waving in 3, and one patient had some substantially meaningful recovery of vision. So it's really these patients with no light perception already where we incise into the soft tissues back there. So I'd like to conclude with that. This is a picture of my campus, very beautiful during these autumn times especially. That's my contact information, and the website for our department, you'll be taken there. If you have any questions or if you'd like to contact me about anything else, please don't hesitate to do so. Thank you very much.